This recording matches to your Ortho and Exercise handout that you've already received. So just to review the stair steps of exercise, so you can kind of see the layout. We've discussed this in lab and you've seen this over and over. It starts down at the bottom with passive range of motion, active assist range, active range gravity eliminated, then either isometric or active range of motion gravity resisted. The second piece for this, so if you start isometric is lower on your stair steps of exercise, the next one would be the active range of motion, or vice versa. And we've talked about how that could have a big impact or be a big difference depending upon the pathology and what the surgeon's restrictions are potentially after some type of injury. Then finally adding some resistance, bands, weights, and then high-level plyometric, weight-bearing exercises, etc. But we need to talk a little bit more in depth about exercise, because exercise doesn't just include all those range of motion type things. It includes the ability to strengthen. It includes our ability to balance. It includes our aerobic capacity and our heart's ability to keep up with our activities. It includes functional activities such as gait and transfers, and includes the ability to have enough flexibility to have our posture in a good upright position and to be able to move against resistance and move with the changing needs of our functionality. So all of these can be considered a type of exercise, even though we've talked pretty much about how active range eventually becomes active range that's resisted and kind of starts with passive. We need to make sure that we include all types of exercise in a patient's program. So when we talk about muscle performance, we need to consider a couple of different things, or a couple of different definitions. First off is strength, is the ability of a muscle to perform a certain activity and give a certain amount of force. But there's also the ability to have power, which is the muscle force plus changing or varying the rate or speed of contraction. So you have to have enough strength to contract, but then in addition, you have to be able to vary the speed. And this is something that I feel like we miss out a lot on in a rehab setting, because we're so focused on strength, 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 but we have to be able to react at a different rate or a different speed to all kinds of different environmental factors. Think about just walking across the street and the sidewalk to cross the street, and you hear the beeping going on to tell you that you need to hurry across the street. Just two different walking speeds is important. So you have to have the ability to vary that. And then endurance is the ability to maintain against repeated force or sustained force. So this is a lot of our muscular endurance, and our stability falls into kind of the endurance category. When we look at intensity of exercise, we need to look at, are we performing, or are we having our patient perform enough strengthening to be functioning out there in the world? So when we look at a 1 rep max, so that's our 1 RM, a patient who is performing strengthening at 80% of our 1 rep max can perform 8 to 9 reps of a particular activity. Now, this is ideal for someone to create muscle hypertrophy and regain strength. Now, if we are working at 60% of our 1 rep max, that patient is going to be able to perform 16 to 20 reps of a particular activity. Now, ideally, in order to build that strength, we want our higher percentages. But think about how we often dose our patients. Sometimes we're giving them 45 reps. What is that 1 rep max? What are we actually looking at with regards to that 1 rep max? We could probably advance them a little bit quicker, but again, we'll talk about later, is educating our patient on what is important for them to feel while they're doing this, so we can be sure that they are performing it appropriately at the 1 rep max recommendation. Now, when it comes to quality of performance, we want to make sure that we are seeing that we have smooth motion throughout the activity, that the patient's able to perform the activity through the full range of motion that we expect without any substitution, good proximal stability, appropriate posture. We're seeing appropriate speed instead of the patient using some sort of momentum, and overall good quality of motion. So what we are documenting is our skill at prescribing that exercise, and this is going to go into our assessment. So we're going to include any cues that the patient needed. So if we needed them to slow down, if we needed to give them verbal cues to move through the full range of motion, if we needed to have tactile cues to make sure that they had good proximal stability or appropriate upright posture during the activity, or decrease upper trap substitution, all of those cues are going to go into our assessment. Or in some clinics, you'll see them included in the actual treatment, as well as any form fatigue noted. So if the motion becomes choppy, or we see a reduction in range of motion as we get into those higher number of reps, or we're seeing substitution, these are all indications of form fatigue. The patient is fatiguing and the form quality is declining. So overall quality, are we seeing an increase in speed? All of these things go into our assessment to give an idea to anyone who's reading that note, what was the actual skill involved in our particular treatment? And these are very, very important pieces, even just to think about down at Hug Clinic. Some other things to consider is altering the velocity to increase the power, using some high intensity training and more aerobic training, mixing it in with some resistance training, educating our patients that delayed onset muscle soreness is good. This doesn't mean that they're having pain during the exercise though. So you need to educate on the difference in what they should be feeling. Incorporate breathing. So have the patient work during the exhale, because the exhale is our diaphragm's relaxation time. So have them work through their exhale, or have them stretch on the exhale, have them count out loud. Those are ways to incorporate breathing. Monitoring vitals. This is going to become supremely important because this is going to be soon the standard of care throughout physical therapy, is to take the heart rate and blood pressure before we even start. How can you know if we are getting an appropriate cardiac response if we don't know where they started? And honestly, I had a patient at the clinic the other day who came in with a little bit of high blood pressure on the eval, and on the second visit, the PTA caught this, took the blood pressure. The patient's blood pressure was 191 over 114. That's emergency room. Holy free holies, we had to send him out. So it's something that we need to be aware of, because if we would have just popped that guy on the treadmill, he could have had a stroke in our clinic. And then altering the variety of surfaces that the patient is performing the exercise on can make it more or less difficult. How much exercise is right? We can look at two different scales for this. You're very familiar with the rate of perceived exertion, but I think you might still have some questions about the MET chart. So a metabolic equivalent chart tells us the amount of oxygen that you need to do a particular activity and how much effort it is. So you're familiar with the RPEs and where a patient should be reporting on a Borg scale based on their heart rate max. But if we look at our MET chart gives us an idea of what physical activities use up a certain amount of energy. So you can see we have very light physical activities all the way to more difficult physical activities on the MET chart. Now, this is important to be aware of because we need to watch the speed that we're having our patients perform certain things, because that speed could have a very profound effect on how difficult it is for the patient. So consider the two different walking speeds here. Very different effects. And then where we might tell our patients to do physical activities at home, how much effort are we actually telling them to perform? So this is something that you can look up further and get links further for your MET charts. We need to make sure that we challenge our patients. If we're not challenging them, if they're not reporting muscle fatigue or we're not seeing form fatigue, that means that the exercise isn't difficult enough. We need to allow them to struggle, and we need to allow them to fail sometimes. Now, not all of the time. So they shouldn't fail on the 4th repetition of an exercise, but they should fail and on balance training alone up to 25% of the time to retrain that cognitive task. Remember, no challenge means that they're not changing, and if we're not creating a change in the muscle, how are we actually strengthening and increasing that capability? And then some modifications. We need to make sure that we are starting a resistance program, even if that's resistance against gravity, before we aerobic train in our geriatric population, because they don't have the same cardiac response. Minimum walking requirements, we need to have an awareness of what that minimum walking requirement is. For community tasks, they should be able to perform approximately a full 6-minute walk test. So that's our goal potentially. And again, vary the speeds. Train on multiple surfaces, stairs, slopes, curbs, grass. We can add discs in the clinic. We can have them sit. We can sit on a ball. We can add cognitive tasks. All of these to make it a little bit more difficult for our patient. And remember, the key to some of this stuff is making sure that the patient knows why, so that they are compliant with their home exercise program and compliant with doing the tasks here in the clinic. That's all, folks.